let's go to the physical exams of a child with colic. You have a child who has colic. How will you, or what physical exam will you look out for? As Dr. Wassam said, we went from head to toe to look at, all the various causes of an inconsolable child, right? Now, if you're examining the child, what are you paying attention to? Number one, pay attention to, even before you get to the child itself, pay attention to the interaction between the child and the parents, how they are interacting. You realize that if the parents are worn out, they are just tired, right? Now, you also want to assess for the temperament and responsiveness of the child to stimulus. Does the child respond to touch? Does the child respond to movement? Maybe at times the mother is rocking the baby, right? And then you also want to assess the growth chart of the baby. If you look at the growth chart of the baby and the growth chart is abnormal, then colic is likely not the cause. So if I give you an MCQ and I tell the child has been crying inconsolably, and you review the growth chart, and the growth chart shows that the child is not gaining weight, likely it is not because of colic. Likely there's a different pathological condition which is causing that. Then, assessment for identifiable causes of prolonged crying in infants. So that's what we went through from head to toe. So when you're learning colic, don't only focus on colic. Learn that there's some ENT causes of inconsolable children. There are some ophthalmologic causes, like the child may scratch the eye, the child may have corneal abrasion, the child may have, glaucoma. There can even be cardiovascular causes like heart failure, like supraventricular tachycardia. There can be genitourinary causes like testicular torsion, strangulated hernia, right? And then you also want to assess the hydration status. Why? Because we said that a child who is crying inconsolably, who is vomiting projectile. We're thinking about pyloric stenosis. It could also be that they are vomiting with diarrhea. That is gastroenteritis. So you also want to assess the hydration status of the child. Because it could also be that the child is not even eating, right? And then you also want to assess the subcutaneous fat. If this child has lost so much subcutaneous fat, then you are concerned because it could be that the child is malnourished. And you also want to check for tongue tie. And if the child has tongue tie, and the child is crying a lot, that means the child is not getting enough food. So it could be that the child has some breastfeeding problems. So you want to assess for tongue tie. And you want to assess the eye. So don't only look at things from the concept of colic. Look at things from the concept of an inconsolable child. So when I examine the eye, what am I looking for? Corneal abrasion, corneal clouding, which may point me to infantile glaucoma, right? And retinal hemorrhage. And retinal hemorrhage, if the child comes in, retinal hemorrhage, the child is lethargic, the child has a frenulum tear, and the child is obtunded. What diagnosis will come into your mind, please? Retinal hemorrhage, frenulum tear, an obtunded child, and the mother looks incessant and angry. What diagnosis will come to your mind?
Shaken baby syndrome.
Shaken baby syndrome. Beautiful. Shaken baby syndrome. Shaken baby syndrome. Shaken baby syndrome. Now, another thing you also want to examine is the mouth. You want to check for thrush. And then you also want to listen to the heart, because we said that it could be due to heart failure, it could be due to supraventricular tachycardia, right? You want to examine for the abdomen, whether there's any tension in the abdomen, whether there's any tenderness, whether there's absence of bowel sounds, right? Because if there's absence of bowel sounds, that's something different. If there's hyperactive bowel sounds, that's also something different. Then you also want to check the diaper area, the perineum, because now it's like you're looking at all the systems we talked about from head to toe, from the head to the toe, where we said the head, it could be due to meningitis, blah, 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 to the eyes, to the mouth. Now you're looking at all of them and you're using them to fit in your differential your physical exam. So notice, if you know your differentials very well and you know how the child will present with those specific differentials, then you can use those differentials to help you to map out your physical exam. So the physical exam, we are not really doing anything unique. We are basically going back to the differentials that we learned about, the head to toe differentials of a crying infant. And we are using that and working step by step by step by step to help us to look for exactly what is happening to the kid. Then you want to check for signs of trauma on the skin. And if there is, any swelling of the joint or abnormality of, a long bony from part, then you may think about a fracture. And you want to do CNS evaluation because you want to check for bulging of the anterior fontanelle, head asymmetry, increased or decreased muscle tone. Then thinking about meningitis. Now, what are the effects of colic on caregivers? Colic, because of the nature of it, can lead to increased risk of postpartum depression. So if you're in your board exam, MCQs, the following are likely complications of colic in the patient's mother, in the child's mother. A, this, B, that, D, C, that, D. And you see postpartum depression and early cessation of breastfeeding. Those are the two typical complications or effects of colic on the caregivers: postpartum depression and early cessation of breastfeeding.